Welcome to this explainer. Today, we are taking on a topic that, let's be honest, often strikes fear into the hearts of students and seasoned clinicians alike: advanced arterial blood gases. But hey, instead of just memorizing rigid patterns, we're going to explore a highly structured, completely logical approach that makes this whole thing so much easier to digest. All right, let's dive right in. Arterial blood gases are the Sudoku puzzles of the nursing world. But ABGs are not random. They follow strict, unbreakable rules of chemistry and physiology. You know, when you first glance at a lab slip with a pH of 7.32, a Pasha CO2 of 50, and a bicarb of 28, it really just looks like a string of random data, doesn't it? But just like a Sudoku puzzle, once you understand the underlying grid, those chemical laws that govern our body's homeostasis, you can solve literally any patient's acid-base status, no matter how complex it gets. So here is our roadmap for today. First up, the ABG Sudoku puzzle. Second, our 6-step diagnostic framework. Third, calculating the anion gap. Fourth, mixed acid-base disorders. And finally, solving a triple threat case. Section 1, the ABG Sudoku puzzle and the unbreakable rules of chemistry. Take a look at this comprehensive flowchart mapping out the logic of acid-base disturbances. I know, it looks super intense, right? But what it actually proves is that there is a clearly mapped out, entirely logical path for diagnosing every single acid-base disturbance out there. Whether that pH is high, low, or deceptively normal, the relationship between carbon dioxide and bicarbonate follows a strictly regulated physiological script. It's a real game changer once you see it. Moving on to Section 2, the 6-step framework, our diagnostic guide. Here are the 6 steps that form our framework. We start by checking internal consistency. Then we determine the primary disorder and evaluate compensation. From there, we calculate the anion gap, assess the delta gap, and finally, we correlate it all clinically. Let's walk through exactly how this structure works in practice. Step 1 is all about internal consistency. Now, when decoding an ABG, advanced with word written out as a strict mathematical formula, like the Henderson equation you see here, it is incredibly powerful. The implication here is absolutely huge. Basically, if the calculated hydrogen ion concentration doesn't match the provided pH, your lab sample is invalid. It could be a laboratory error, maybe an air bubble in the syringe, who knows, but you absolutely must verify the numbers are real before you start interpreting them. Assuming the sample is valid and you've nailed down the primary disorder based on the pH, step 3 is evaluating compensation. To do this, we rely on these bedside rules. For example, in metabolic acidosis, for every 1-point drop in bicarb, we expect exactly a 1-point drop in PCO2 because the lungs hyperventilate to blow off that acid. So the crucial takeaway here is this: when the patient's actual compensation doesn't perfectly match these strict mathematical rules, that is a massive, glaring clue pointing directly to a hidden second disorder. Section 3, calculating the anion gap to find hidden acid. Now, if you find an elevated anion gap, meaning the patient has a high anion gap metabolic acidosis, or HAGMA for short, you move immediately to step 5, which is the delta gap. The delta gap ratio compares the change in the anion gap directly against the change in bicarb. It's essentially asking a simple question: does the rise in the gap fully explain the fall in the bicarb? The delta gap acts exactly like a diagnostic magnifying glass. If the ratio is exactly between 1.0 and 2.0, you have a pure high anion gap metabolic acidosis. But if the ratio is less than 1.0, it means the bicarbonate has fallen way more than the gap has actually risen. This proves a concurrent non-anion gap metabolic acidosis is hiding in the background. Conversely, if the ratio is greater than 2.0, the bicarbonate hasn't fallen as much as it should have, which reveals a concurrent hidden metabolic alkalosis. Mind-blowing, right? Section 4, advanced mixed acid-base disorders, navigating multiple disorders at once. Let's compare 2 incredibly common clinical scenarios where massive biochemical abnormalities dangerously mask each other. Take a patient with sepsis or salicylic toxicity, like a severe aspirin overdose. The toxin causes a severe metabolic acidosis, sure, but it also directly stimulates the brain to hyperventilate, causing a primary respiratory alkalosis. On the flip side, consider a patient with chronic COPD who retains CO2, giving them a respiratory acidosis. But what if they start suffering from severe vomiting? Well, they lose stomach acid, creating a concurrent metabolic alkalosis. In both of these cases, the competing disorders can pull the pH right back to a deceptively normal level. Which brings us to the ultimate rule of thumb for this entire explainer. If the PaCO2 or the bicarbonate doesn't strictly match the expected compensation calculated from our bedside rules, you need to think mixed disorder. Any compensation that falls short or pushes way too far is your mathematical proof that a second problem is hiding right there in the blood gas. Section 5. The triple threat case, the ultimate clinical challenge. Okay, here are the clinical facts for our case study. We've got a 70-year-old male with a history of congestive heart failure and chronic COPD. His current complaint? 5 days of severe vomiting. And here are his frankly baffling labs. His pH is 7.48, his PCO2 is 32, his bicarb is 23, the lab measured an anion gap of 33, and his albumin is very low at 2.0. So, just looking at those numbers, what on earth is hiding in this data? A pH of 7.48 is just barely alkalemic. Honestly, it almost looks like a mild disturbance. But given the severe, chronic, and acute issues in this patient's history, we know better than to trust that at face value. Let's unleash our systematic framework on this puzzle. Step 1. We assume the sample is internally consistent. Step 2. The pH is 7.48, which dictates our primary disorder is an alkalemia. Step 3. We look at the PCO2, which is low at 32. Now, because the pH went up and the CO2 went down, moving in opposite directions, this confirms a primary respiratory alkalosis, likely from his congestive heart failure causing respiratory distress. Now let's evaluate compensation. For an acute respiratory alkalosis, the bicarb should drop, but his bicarb is 23. That's basically normal, meaning it's way too high for his expected compensation. That inappropriate compensation immediately flags our second disorder, a concurrent metabolic alkalosis, perfectly explained by his 5 days of severe vomiting. But wait, we aren't done. Step 4 mandates we check the anion gap. Because his albumin is low, we have to use the corrected anion gap formula. And let's get that math down with the word written out specifically for our patient's variables. We take his measured gap of 33 and add 2.5 times the difference between normal albumin and his albumin. That equals a true anion gap of 38. This reveals a massive, profound, high anion gap metabolic acidosis, likely electric acidosis from poor tissue perfusion hiding right beneath the surface. And finally, step 5, the delta gap. We calculate the change in his true anion gap, which is 38 minus a normal 12, giving us a delta Ag of 26. We compare that to his change in bicarb, which is a normal 24 minus his 23, giving a delta bicarb of 1. 26 divided by 1 is a massive ratio that is well over our 2.0 threshold. This mathematically proves without a shadow of a doubt that the metabolic alkalosis we suspected in step 3 is absolutely present and significant. Which leads to our final brilliant diagnosis for this patient. He is actually suffering from a triple disorder. He has a primary respiratory alkalosis driven by CHF to stress. He has a profound high anion gap metabolic acidosis, likely from lactic acid, and he has a concurrent metabolic alkalosis driven by his severe vomiting. We took a set of chaotic, contradictory numbers with a borderline normal pH and systematically decoded them into 3 distinct, life-threatening pathologies. This is the true power of our framework. We don't guess, we calculate. So I leave you with this final thought. By treating ABGs like a puzzle governed by strict physiological laws, rather than just random data points, how many hidden, life-threatening disorders will you uncover on your very next shift?